Can we have the PowerPoint of Dr. Ur?
Microvasculature and visual acuity before and after intravitreal anti-VEGF injection in DME patients. So we know it's not moving. Excuse me.
Down arrow.
So we know that anti-VEGF agents are the mainstay of treatment in DME, and for FFA and OCTA help to visualize the retinal microvasculature. So the primary objective was to assess the retinal vascular area, the phase area, and the number of microaneurysms at both SCP and DCP before and after intravitreal anti-VEGF injections. So it was a retroprospective longitudinal study conducting at a tertiary eye care institute, which included 77 patients. Patients having a central macular thickness of more than 300 microns who received at least 2 anti-VEGF injections having a follow-up of 6 months but with good quality images were included in the study. So EMR was assessed for the demographics, the visual acuity and the OCT images. Anti-VEGF injections were given monthly for 3 months followed by a PRN regimen. Retreatment was indicated if CMT increased to more than 300 microns, or if there was exudation, or if there was a drop in vision. PRP was done wherever indicated. OCTA was done using the Heidelberg Spectralis machine, including a central 30-degree 6x6 mm scan. Automated segmentation was done into superficial, deep capillary plexus, outer retina and choroid. The image analysis was done using ImageJ software. All the images were transported into the software, converted into the 8-bit image. Then with the manual hand selection tool, the area was delineated. With the analysis tool, a scale was set of pixels per mm and the area was measured. So in this way, the phase area was calculated to be in this image as at DCP as 0.178 pixels per mm square. Similarly, microaneurysms, the image on the right is the image of the deep superficial capillary plexus, whereas on the right is of the deep capillary plexus, which shows the microaneurysms as saccular dilatations marked with red circles. This is the OCT image showing the retinal avascular area, which was done after converting the image into the binary form. So total 71 eyes with good quality images were taken. There was a mean change in mean number of microaneurysms decreased significantly both at SCP and DCP. The phase area also decreased in SCP and DCP at 6 months. At 6 months, the retinal avascular area decreased significantly at both the SCP and the DCP levels. And it was also correlated with the mean visual acuity, which improved significantly at 6 months, which was my secondary objective. So previously, Soror et al. Had showed that vascular density remained statistically unchanged. However, in my study, the avascular area decreased both at DCP and SCP, and we found a weak positive correlation with BCVA. Similarly, El-Nairi et al. In their study showed that there was a significant increase in the phase area. However, in my study, the mean phase area decreased, suggesting improvement in the macular perfusion. Bromeo et al. In their study also showed that phase area remained statistically unchanged, which was contrary to this. Our study showed that it decreased. Meleka et al. Shows that microaneurysms were seen better at the deep capillary plexus level, which was a similar result in our study. The limitations of my study majorly was the segmentation error. However, we tried as much as possible to manually improve the segmentation. And mean area may not detect focal areas, and phase area may vary even in normal individuals. So the conclusion, this was a study done to see the OCTA characteristics on the Heidelberg machine in Indian eyes after the removal of projection artifacts and manual segmentation, and retinal perfusion and phase area both improved, correlating with the improvement in visual acuity. Thank you.
Judges, questions?
So how do you explain the improvement of your foveal vasculature? Because
with injection, the ischemia decreased. So like the improvement in the retinal perfusion, which was like majorly seen at the macula, with subsequent injection, the retinal perfusion increased, which was reflected at the macula.
You have not mentioned what drug the patients have received?
Ma'am, they received 3 types of injections: ranibizumab, bevacizumab and aflibercept.
So did you see any difference across these 3 drugs?
Ma'am, due to the large sample size and the study time was very limited, because I had to submit it to the DNB, so I did not study the inter-drug, the cross-sectional.
So if the patients have maintained on the same drug throughout, it shouldn't have been a very difficult statistical analysis to do.
Ma'am, it was like if subsequently after 3 injections, some patients changed the drug in the PRN regimen. So I followed them only till 3 injections.
So if they have not changed it in the 3 injections and you have followed the patients, you could have analyzed the difference between the drug.
Yes,
Yeah,
ma'am.
and though there is a reduction in macular edema, which of course you have not even mentioned the OCT findings, you have only mentioned the OCTA findings. OCT findings should also be there along with it for completion of data and for proper correlation. But there isn't any evidence of anti-VEGFs improving perfusion. So how do you explain your improved FAZ area?
Ma'am,
Yeah.
it could be because the foveal avascular zone was distorted before the injections, and as the macular edema improved, like the cysts when they dissolved, it became more compact.
Exactly.
And it could be the
Yes, so
because of
that is your reason, that because when there is an edema, the vessels get pulled apart, and that is a known artifact in OCTA, that it causes a false enlargement of FAZ when you have edema. And when the edema reduces, they come back. So that may not be really an improvement, but it's the improvement in the edema which is giving you a false finding of improved reduction or improved perfusion in the FAZ.
What was your total sample size that you have not mentioned?
77 eyes, ma'am.
71. And have you included the patients from both the types of diabetes, insulin dependent? That also you have not separately mentioned. And whether the duration of the diabetes, diabetic retinopathy or duration of diabetes, that is also not mentioned. And what was your exclusion criteria?
Ma'am, patients, exclusion criteria, patients which had other ocular
That is,
other
that is also not mentioned. And as ma'am has rightly said, the number of cases you have allotted to each group, that should have been tabulated properly. That is again not included.
I will make these changes again. If I send this for publication, I will consider your comments.
The time period also, the time period after which you have...
On alterations in retrobulbar hemodynamics after decompression surgery for inactive thyroid eye disease patients, moderate to severe thyroid eye disease patients. So a disclaimer, this article of my thesis has already been published in Eye last year. So we know in inactive thyroid eye disease, there is decrease in the blood flow. Active disease has inflammation and increased blood flow, and inactive disease has decreased blood flow, which can lead to ischemia at the optic nerve head and lead to ischemic kind of dysthyroid optic neuropathy, which is different from the compressive optic neuropathy. So we measured the blood flow in the central retinal artery and the ophthalmic artery using color Doppler imaging, and we calculated the resistivity index as shown in the formula. So the literature does not show any details about what happens with orbital decompression surgery in inactive patients. So we studied that using color Doppler. This was my study pattern. We had 3 groups. One group who needed surgery, who were ready for surgery. Second group, similar patients who did not consent for surgery. And third group were healthy controls with refractive errors and no other orbital disorders. And we excluded all systemic disorders and smokers who would have some vascular compromise. These are the demographics of my study. So we included 24 patients, and these are the pre-op and the post-op photographs where we can see that post-decompression, the edema has reduced, and in the left side images, we can see the proptosis has reduced. Now coming to the parameters, proptosis definitely reduced significantly, intraocular pressures, they reduced. Central retinal artery, velocities increased and resistance decreased, same with ophthalmic artery, and all these changes were significant before and after surgery. And these are the images of the color Doppler which we saw, where you can see the pre-op and the post-op, the waveforms of the velocity on color Doppler, they have significantly increased in each of the arteries. The group B, where there was no surgical intervention done, who were just observed for 3 months, there was no significant change in Doppler flow, which suggests natural course of disease. Over 3 months, the blood flow did not change, it remained low. And when compared with the normal controls, the thyroid group had significantly reduced perfusion indices. So using this, we made area under curve analysis. And when we compared the healthy with the thyroid orbits, we found that ophthalmic artery parameters, they had very high area under curve, almost 0.9. And we could establish some cutoffs. And we could also establish cutoffs to determine the severity of the disease. So what new this study adds is orbital decompression, it relieves the space volume conflict in the orbit in thyroid eye disease. But we hereby prove that it also improves the orbital perfusion in the central retinal artery and the ophthalmic artery. Thus, it will prevent the ischemia in the orbit and subsequent optic neuropathy in predisposed patients. Like orbital perfusion has already a proven role in normal tension glaucoma, and recently in POAG and PSEG, we hereby prove the role in thyroid eye disease as well. We could establish cutoffs to distinguish between a healthy and a thyroid orbit, and also to determine the severity of thyroid orbits. So this could add as an adjunct to the CAS scoring which we use right now. And so these were the places where our gates were placed, and how any lesion distal would have affected the end diastolic velocity, and any lesion proximal would have affected the peak systolic velocity. And these are the main sites of resistance: the intraocular microvasculature, the compression at the orbit, and the muscles. So we can't actually do anything about the first two. We could relieve the direct compression of the vessels at the orbit using a decompression surgery, and thus we can reduce the resistance and improve the perfusion. Thank you.
Just one question I have to ask. Now you are just did you have that cutoff, and did you see in which type of thyroid eye disease, like mild, moderate, did any difference, or just you have taken only those cases who are undergoing the surgery, decompression surgery?
Ma'am, we took inactive patients for more than 6 months who were inactive and who did not respond to steroids, and those were our moderate to severe patients. And the patients who did not undergo surgery, they were mild, or the patients who underwent surgery and the other eye was classified as mild. And using those findings, we
And
classified
what about
them.
the active group?
Ma'am, active group we did not take because there are very few indications for surgery in active, like dysthyroid compressive neuropathy or exposure keratopathy, and those could independently affect the perfusion because of inflammation. And smokers also we excluded all
No,
of
because we don't have a baseline, so you should have seen in all along with the normal case
them. Ma'am,
also.
those could have been potential
Yeah.
confounders in our statistical analysis.
Yes.
So we studied only the inactive group of
Okay.
thyroid eye disease patients. Sir, between the groups A and B, who underwent surgery and who did not, they were age matched and gender matched groups. So any confounding effect of the age was removed using that.
So you were saying it is inactive cases you have taken.
Yes, ma'am.
So what were your indications for surgery in those cases?
Ma'am, either the patients wanted cosmesis because one of their eye was proptosed, that was cosmetic decompression was one, and second, who did not have any clinical drop in vision, but they had reduced contrast, they had reduced color vision, reduced field of vision with normal IOPs and a normal healthy looking disc and macula. There we offered them the option because studies have shown reduced perfusion to the optic nerve head, but no study shows orbital decompression and any changes. So those patients we had been following up for 1 or 2 years at our center before we enrolled them for the study, and post that we have a 1 to 1.5 year follow-up right now, and they are clinically happy that they are able to appreciate, they are able to drive better, and that's what. We had 3 patients like that, so they could have been a subclinical optic neuropathy because we did not use VEP in this to correlate. We could have used that latency and amplitude could have changed in those patients, but they did not progress. Their quality of vision was maintained before and after the surgery, and they were happy. So that is a potential indication that ocular perfusion biomarkers, using color Doppler, it could act as an adjunct. Like we could quantitatively determine where the thyroid eye disease is instead of our qualitative assessment on clinical basis. Like how visual fields have helped in glaucoma, this could help in thyroid eye disease management in future. Sir, we went for a lateral, deep lateral. Yes, sir. A lateral orbitotomy incision and a deep lateral wall decompression, and it was uniform across all 24 eyes.
In methodology, it should have been described in detail which type of orbitotomy was done. In demographics also, the male to female ratio, the preoperative visual acuity,
Yes.
the postoperative visual acuity, all these things should have been mentioned in your study.
Ma'am, the demographics and everything was mentioned, male, female, and visual acuity, but I just breezed through it because
Because that is important.
Yes, ma'am, it's important. Our median visual acuity was 0.1 logmar units, and we did not do a mean because most of them were 0, so our mean was coming out to be 0. So median was 0.1 with an interquartile range of 0 to 0.2 logmar units.
Was there any criteria related to optic nerve status on fundoscopy?
Yes, ma'am. We ruled out any patients who had an established dysthyroid optic neuropathy or an optic neuropathy or an optic atrophy due to any other reason. We had ruled those cases out. So we had taken vision, pupillary reactions, fundus examination, and as our primary parameters. We did not use color vision, contrast, and visual field.
So next speaker is Dr. Jayashree. Yeah, please.
Good afternoon. Good afternoon, everyone. I'm here to present on a comparison of single-dose vector thermal pulsation procedure with 5 days course of daily oral azithromycin for meibomian gland dysfunction. As we all know, meibomian gland dysfunction is a chronic diffuse abnormality of the meibomian gland characterized by the terminal duct obstruction. Goal of all treatment modalities available is to improve the flow of the meibomian gland secretion by removing the obstructed meibum, thus leading to the normal tear film stability. Coming to the Lacanian literature, VTP is a newly launched procedure in India, and to the best of our knowledge, there was no study comparing its effect on meibomian gland dysfunction with the oral azithromycin in our population. It is a prospective non-randomized comparative analysis done in eye foundation with a follow-up period of 6 months. Coming to the inclusion criteria, patients who are above 18 years of age who are willing to undergo the procedure with a MGD score of speed score of more than or equal to 6, OJ score of more than or equal to 18, LLT of less than or equal to 60, and meibomian gland score less than or equal to 6 and reported dry eye symptoms within 3 months. And patients who had more than or equal to 50% observable meibomian gland structure determined by the meibography, and no reported history or of allergy or sensitivity to azithromycin. The speed and the OSA score are assessed using the corresponding questionnaire. Patients who are having ocular inflammation or infection, ocular surface abnormality or eyelid abnormality, or patients who have a systemic disease that cause dry eyes such as Sjogren's or rheumatoid are excluded, who underwent punctal occlusion or punctal plug within 3 months, and also who has less than 50% observable meibography, meibomian structure determined by the meibography are excluded. After getting an informed consent, a symptomatic assessment is done using speed and OSA questionnaire. Written examination is done for grading the meibomian gland score, and lipid scan is done to assess the lipid layer thickness, and T-BET and shimmers is done subsequently. After the initial assessment, the patient is informed about 2 modalities of treatment. For the VTP, a heat of 42.5 degrees Celsius is applied with a pulsating pressure of 0.5 to 5.5 psi. And for antibiotic group, 5 days of tablet azithromycin, 500 mg on day 1 and 250 for the subsequent days is given. For the post-treatment is also done similarly after 2 weeks of the procedure. Sample size was calculated using Higenby et al. As a mother study, and 27 patients per group was added, and according to the attrition rate, 30 eyes were included for every group. And the statistical analysis is done using for continuous variables student t-test and categorical data, Pearson chi-square test was done. Coming to the results, most of the patients were above 61 years of age with no statistical difference between 2 groups, and most were females. And the speed score, the symptomatic improvement, statistically significant difference was noted in speed score in post-treatment follow-up in 3 months, 6 months in both groups, and also in OSA score, whereas there is no statistically significant difference noted in the lipid layer thickness. T-BET also increased statistically significant, and there is a significant improvement in 2 weeks in azithromycin group, and the improvement mildly deteriorated in the subsequent follow-ups. Whereas in lipid flow, the improvement lasted throughout the follow-up periods. And for shimmers also, there is no statistically significant difference noted between the follow-up periods. Meibomian gland score also showed a statistically significant improvement. When comparing the mean difference of speed score between the pre-treatment and post-treatment, both the speed, OSA, everything improved at the subsequent follow-up visits. Coming to the summary, our study found that both azithromycin and lipiflow treatment are effective in patients with MGD. The effect of lipiflow treatment lasted for longer follow-up period. Considering the cost of the treatment, lipiflow is out of reach for patients with lower socioeconomic status. And efficacy of azithromycin in resolving symptoms of MGD was greater compared to lipiflow in the initial 2 weeks. However, the effect deteriorated in the subsequent follow-up. Azithromycin being a readily available and affordable by all, can be used as a cost-effective alternative for treatment of MGD. Further studies are required to determine the dosage, duration, and treatment in which azithromycin can be used for longer lasting clinical benefit. And further studies are required to determine the duration of action of azithromycin on ocular tissues. Chronic patients, ma'am.
Chronic cases, how it, like one dose of vector pulse therapy and 5 days course of azithromycin, how do you like expect to get improvement in chronic cases of MGD?
Ma'am, we also excluded the patients, like when there is meibomian gland dropout, we didn't include those patients, ma'am, when there is a observable meibomian gland, so that when we like remove the occlusion using the pressure, like they can resume the secretion.
Were they supplemented with any local therapy?
Yes, sir.
Because that's not mentioned.
Have you not included the adjuvant therapy like hot fomentation, lead massage?
Yes, sir. Yes, sir.
So you have not mentioned about that. It should be continued with this. As Madam has told you that single sitting of Lipiflow or 5 days
Sir,
dose
we
of
supplemented
azithromycin
with the,
will
local
not
therapy.
sustain the. It is not the complete treatment. You have to adjuvant, give the adjuvant therapy also. You have not talk about that.
Local therapies.
Did you rule out any infection of the meibomian glands? Because you are using antibiotics in these cases,
Yes,
azithromycin.
ma'am. Patients with any inflammation or infection is excluded.
How did you rule out infection?
Ma'am, acute infection.
How did you rule out?
Ma'am, shorter duration. Sir, sir, infection. So there is no any pain, like we excluded.
You concluded saying that Lipiflow was better in the long term, but lot of your graphs showed the azithromycin thing having higher. So you enumerated some criteria and you skipped over some slides. So when you're saying Lipiflow was better, what was your criteria to say Lipiflow was better in your data?
Ma'am, azithromycin, there is a significant improvement noted at 2 weeks. But the when comparing 2 weeks between the azithromycin and Lipiflow, azithromycin was better at 2 weeks. But during the subsequent follow-up, because of the bioavailability of the drug, this has subsided. But Lipiflow, it was constantly maintained.
What was maintained? You had so many criteria, right? You showed so many graphs.
Yes, sir.
So out of all of those criteria, how many were better in Lipiflow? How many were better in azithromycin? And to conclude statistically, in the end, which was more significant? What did you do a multivariate analysis or a univariate analysis? Did you come to find which factor was most affected by which modality of treatment?
Ma'am, all the factors were improved at 2 weeks, better than Lipiflow in azithromycin, ma'am, but there is a drop. Like only Shimas was not significantly affected.
What is the inference of your study? What is the inference of your study, which you like to know?
Azithromycin was better at 2 weeks. Like Lipiflow is costlier, sir. So for patients,
Not the question of the costly remedy. Which modality of treatment your inference says is better?
Sir, Lipiflow for longer.
What are the criteria which are showing that this is better? So you have done that analysis, no? So tell us. That is what.
Ma'am, all improved, ma'am. All improved.
Can we move on to the next speaker?
Thank you. Thank you.
Dr. Anku.
Next. Acha, Anku.
Good afternoon, judges. The title of my topic is Evaluation of the Visual Cortex Activity Using Functional Near-Infrared Spectroscopy in Primary Glaucoma. Glaucoma being a major cause of the irreversible blindness in the world, although lowering the intraocular pressure is the current mainstay modality, but there has been recent studies which emphasize on the relationship between the glaucoma and the altered cortical hemodynamics. So FNES is an emerging cost-effective non-invasive neuroimaging techniques which helps in monitoring the brain response and thereby helping in the functional brain mapping. The primary objective of my study was to evaluate the visual cortex activity using a continuous wave functional near-infrared spectroscopy in primary open-angle glaucoma as well as the primary angle closure glaucoma compared to the healthy controls. And subsequently, the secondary objective was to analyze the association of this visual cortex activity with the visual field defects and the retinal nerve fiber layer thickness. A total of 30 primary open angle glaucoma, 31 primary angle closure glaucoma, and 30 healthy age-matched controls were recruited. It was in the inclusion criteria were patients with a primary open angle glaucoma and the primary angle closure glaucoma with reproducible visual field defects according to the HPA classification, age more than 40 years. While for the controls, it was age more than 40 years and no other ocular disease other than the refractive error with best corrected visual acuity of 6/18. We have excluded patients with other comorbid ocular conditions other than the primary glaucoma for the cases, and any CNS disorders like the stroke, dementia, or the psychiatric illness, or any other ocular surgery history. Similarly, for the controls, any other ocular disease or the CNS disorders were excluded. So all my patients, they underwent the FNES testing using a multi-channel near-infrared NIRS port device. It consisted of 8 light-emitting diode sources and 7 detectors. So we used the wavelengths of 760 nanometer and 850 nanometer. Here, standard visual stimulus of flickering checkerboard of 1 Hz was used. The visual cortex activity was evaluated in terms of the maximum amplitude of change in the oxyhemoglobin over 10 seconds, and a comparison was done between the 3 groups. The statistical analysis was done using the SPSS versions 29. The change in the oxyhemoglobin, which we had evaluated, was compared among the 3 groups using the ANOVA, followed by a post-hoc Turkish honest significance test for comparing the group differences between any 2 groups. The Pearson correlation was then conducted to assess the relationship between the maximum, the visual cortex activity and the disease severity. It was an age-matched patient distribution. The mean age was 53 years among all the 3 groups. The POAG and the PACG were classified based on the severity according to the HPA classification and were found to be similar in the severity distribution. Now coming on to the results, a characteristic response of increased oxyhemoglobin during the stimulus presentation was seen in all the participants. So here we have seen that the maximum amplitude of change in the oxyhemoglobin concentration was significantly lower in the primary open angle glaucoma and the primary angle closure glaucoma compared to the healthy controls in the right and the left middle occipital gyri, while there was no significant difference between the 2 glaucoma groups. This is a table showing the channels with a significant difference in the maximum amplitude between the PACG, POAG, and the control groups. Now coming on to the association of the visual cortex activity with the disease severity. Now this graph is for assessing the visual cortex activity with the visual field mean deviation. Here we can see that there is a significant negative correlation of the visual field mean deviation with the visual cortex activity. Using the Bonferrini correction, we saw that in channel 10 and channel 16, which corresponds to the cuneus and the right middle occipital gyri and the right superior occipital gyri, they showed the significant negative correlation. Now, and in the results, comparing the association of the visual cortex activity with the RNFL thickness in the glaucoma group, there was a positive correlation. So what we have in this, we can say that there is a lower occipital cortex activity after the visual stimulation in the primary open angle glaucoma and the primary angle closure glaucoma compared to the healthy individuals. And there was a negative correlation between the visual cortex activity with the visual field defects and a positive correlation with the RNFL thickness. So we can suggest that there may be a decrease in the occipital cortex activity in the primary glaucoma, and the disease severity appears to correlate with the cortical activity. So what we can say that the decrease in the cortical activity is because of the transsynaptic structural damage and the multi-level neuronal degeneration in the occipital region of the glaucoma patients. The limitation of my study is that it was a cross-sectional studies, observational study with a small sample size, and the continuous wave near-infrared spectroscopy, it cannot estimate the absolute values of the optical properties, like the time domain FNES and the frequency domain FNES. So the main conclusion of my study is that in individuals with primary glaucoma, there is reduced occipital cortex activation than the healthy individuals for a visual task, which seems to closely associated with the visual disease severity. So the continuous functional near-infrared spectroscopy is a non-invasive, cost-effective neuroimaging technique which can be beneficial in understanding the neurodegenerative changes in the glaucoma. Thank you.
Any questions?
Yes, sir.
Tried VEP in these patients?
VEP, no, sir. We did not. In our study, we haven't conducted the VEP as such. But in a previous study of my chief guide, they have done the VEP study with the ECG changes and EEG changes. Sir, the VEP study that was conducted, other study, there also they have showed that in the mild to moderate, it was done in the mild to moderate glaucoma patient. So in the VEP changes like in the EEG, so yes, sir. So yes, sir. So in the glaucoma patients, like with the increasing severity of the disease, there were changes in the VEP. Like, so VEP as such, we did not conduct a different study. Sorry, sir. Sorry.
In your study, you chose mild and moderate glaucomas.
Ma'am, mild, moderate, severe.
Severe. So
yes, ma'am.
how did it correlate?
Ma'am, with the increasing severity, like for the first was to assess the difference between the glaucoma and the healthy. Then after the glaucoma, we have taken with this increasing severity, there is decrease in the occipital visual cortex activity.
How did it correlate with their visual fields?
Ma'am, as the visual field, the mean deviation, we have taken the mean deviation. So as it rises, the mean deviation, it increases, the visual cortex activity is decreasing. That's the...
And there was no significant cataract, refractive
We
error?
have excluded
All
that.
of that has been excluded
Yes,
and
ma'am.
taken care of.
Yes, ma'am.
Thank you.
Okay, thank you.
So next speaker.
So why we need this?
Prospective comparative study of lenticular thickness and effective lens position in diabetics and non-diabetics undergoing cataract surgery in a tertiary care center. As we know that nowadays patients have heightened expectations for the visual outcome post-cataract surgery. Therefore, accuracy in the IOL power calculation is very important apart from the surgeon's surgical skill. Anterior chamber depth is important because it is an indirect measurement of the effective lens position, that is ELP, which is distance between cornea and the anterior surface of the IOL. Diabetes prevalence is increasing nowadays, and we know that diabetes causes changes in the osmotic property of the lens. Therefore, our main objective is to calculate the lenticular thickness in diabetics and non-diabetics preoperatively, and to calculate and compare the ELP, that is effective lens position, and the visual outcome post-operatively between both the groups. So therefore, we want to compare about the diabetes. We want to know about the diabetic impact on the eyes. The methodology is 100 cataract patients who presented to our OPD. They were of the age group of 40 to 70 years, and they were divided into two groups, 50 diabetics, 50 non-diabetics. The study period was 18 months, and comprehensive examination, visual examination was done, and biometry was done using APPA AMAX scan, which was using SRKT formula in all the cases. Lenticular thickness and ACD was measured, and cataract surgery was done. That was manual cataract surgery, and 1 month post-operatively, the vision was assessed and the anterior chamber depth was assessed. Patients were followed up and the results were compared and analyzed. So our results were, the majority of them were in the age group of 60 to 69 years. Majority were females. Majority of the right eye was operated, and IOL used was between the range of 12 to 28 diopters, in which majority were in the 22 to 24 diopters. The pre-operative ACD in both the groups were not statistically significant, and the post-operative ACD in both the groups were also not statistically significant. What was statistically significant was the lenticular thickness in the diabetics, which was statistically significant, and diabetics tend to have a thicker lens, that was 4.2, and non-diabetics had a thinner lens, that is 4. But the cataract definitely had the change in the ACD values, like intra-group statistical significance was significant, like in non-diabetics pre-operative ACD and the post-operative ACD was statistically significant, and same in the diabetic group also. The main outcome of our study was the spherical error. The spherical error was not much, that it was 0.5 diopters in 50% of both the groups, and it was not statistically significant. So therefore, our study concludes that diabetic patients had the thicker lens, and the other studies also had the similar results. The anterior chamber depth preoperative was in the range of 2.7 in diabetic and non-diabetic group. That was also comparable in the other groups. It was the same in the other studies. So even though we know that the anterior chamber depth has the correlation it is the indirect measurement of the effective lens position, but here in our study we couldn't find anything as such. Nearly 50% of both the diabetic and non-diabetic groups had no post-operative surprises and had no post-operative refractive error. It was less than 1 diopter, and equal good results were seen in both the groups using SRKT formulae. Thank you.
You actually seem to have just found a slightly thicker lens in the diabetics as compared to the non-diabetics. And while you have said statistically significant, your p-value is not mentioned. So do you
P-value is 0.38, ma'am.
0.38.
Yes.
So that is not
0.038. Sorry, this 0.038. My slide.
That's mildly significant, if at all. And when you are mentioning pre and post AC depth, you are looking in the same group. You are looking at controls pre and post. You are looking at diabetics pre and post. Of course, it's going to increase post. Your IOL is much lesser thickness than a natural lens. So that is a no-brainer, actually. Was there a difference between the AC depth pre and post amongst the two groups, across the two groups? You are comparing controls and diabetics.
No, so controls and diabetics, when we compared in the pre-op and post-op, after the cataract surgery was statistically significant.
In the same group, you are compared pre of cataract with pre of control with post of control, and you have compared pre of diabetics with post of diabetics. What about post surgery AC depth of control versus post surgery AC depth?
Also we have compared, ma'am. Like we have compared both the things. Pre-operative ACD in diabetics and pre-op ACD in non-diabetics. That was not statistically significant. Post-op in diabetics and post-op in non-diabetics, that was also not statistically significant.
Exactly. So what benefit do we gain from this knowledge? Did it make any difference? Was the thicker lens causing any problems in surgery? Was it causing any shallowing of AC? Was surgery more complicated due to that?
No, we couldn't find, in our scenario, we didn't had much significant on this thing.
Bottom line is that, what is the rationale of this study? What you wanted to prove? Which hypothesis you wanted to prove? What was the rationale?
The lenticular thickness, what we found was lenticular thickness was more in diabetics. But visual outcome, yes.
Why? Why? Why was the lens thicker in diabetics as compared to controls?
Because of the osmotic changes, ma'am. We wanted to know that if lenticular thickness is more, then the ACD will reduce.
The sugar is getting metabolized through sorbitol aldose reductase pathway.
Yes.
That is, we are all known to it. What was the rationale of the study? Once it is 200 milligram % more than that, hexokinase become redundant. Aldose reductase start taking place.
Yes.
Mechanism of the utilization of the glucose start taking place.
No, because we
aldose
wanted
reductase pathway.
to...
Rationale bataiye.
No, the thing is we wanted to prove that if that lenticular thickness, the idea behind the study was if the lenticular thickness is more, then the ACD will reduce. And that ACD reduction might have any change in the IOL. But we couldn't find any such correlation in our study.
Okay.
That was the main idea behind our study.
Okay, thank you.
Thank you.
Next is Dr.
Whether there were any refractive
Pragya.
surprises is what she wants to say. But there were not.
The basic thing is that whether if she did his study on thickness and any complication happened during the surgery just because of this LCD, that was a real and ideal question for it. Basically, it's a problem of us teachers who allot them thesis, not the candidate.
I agree.
Dr. Pragya, please.
Good morning, respected judges and fellow colleagues. I'll be discussing my thesis on study of candidate gene polymorphism in patients of diabetic retinopathy in Indian population. I have no conflict of interest or financial disclosures to disclose. First, I'll come to why did we why are we focusing on RAGE gene? It has been shown that the microvascular complications of diabetes at the sites, they have high age, advanced glycation end product formation. The age is attached to the RAGE gene which is coded by chromosome 6, a member of the immunoglobulin superfamily. This chronic activation of this RAGE gene has a role in the diabetic microvascular complications. Identifying genes that may be responsible for the severity may help in understanding may help us understand better the pathogenesis of diabetic retinopathy. The aim was to detect two polymorphisms, 374T replaced by A and 429 thymine replaced by cytosine in the single nucleotide polymorphisms in RAGE gene in healthy controls, diabetic patients with and without retinopathy. These were the two polymorphisms which were studied in the promoter region of the gene. It was a prospective case control study with 90 subjects, 30 healthy, 30 diabetics with retinopathy and 30 without. It was done in Retina Clinic at AMU. 10 ml of blood sample was collected following WHO precautions. 7 ml was kept for biochemical investigations and 3 ml was taken up for genetic analysis. First, these samples were first subjected to centrifugation and then stored in EDTA vacuotainers at -80 degrees Celsius till it was time to analyze them. Spin column based DNA isolation kit using the manufacturing instructions were used for DNA isolation, and when the DNA isolation was done, samples which had purity less than 1.7 to 1.9 were excluded from the study. The DNA samples were amplified using PCR, and specific restriction endonucleases ALO1 and TSP509I were included with specific incubation periods, and restriction fragment length polymorphism was actually used to determine the band length, and this was imaged using the BioRad software. These were the two bands that we achieved. The length of these bands was correlated with an image which was given by Barry Hudson et al. With the Pioneer study in 2000, where he gave which polymorphism will correlate with the length of the band achieved. Results of my study: 374T thymine replaced by adenine polymorphism was significantly associated with patients of diabetic retinopathy with a p-value of 0.01. Of the examined polymorphisms, only the mutant allele, that is the adenine, was seen to correlate with the severity of diabetic retinopathy. We assumed this was all assuming the dominant model of inheritance. 429 thymine replaced by cytosine was not associated with diabetic retinopathy. When compared with healthy controls, the diabetics and the 374T by A polymorphism was more in diabetics and diabetics without retinopathy. However, this correlation when done between diabetic without retinopathy and diabetic patients was not significant. However, the odds of patients having this polymorphism in diabetics with retinopathy was more. No such correlation was seen for 429T by C. Duration of diabetes was a significant risk factor for development of diabetic retinopathy. HDL, blood glucose, fasting PP, serum creatinine was significantly associated with patients of diabetic retinopathy. In hemogram, RBC count and MCHC were significantly correlated. We believe this is an incidental finding. What is the relevance of our research to the existing clinical science? The existing results which are controversial with no common consensus within them. This is the second study from the Indian subcontinent with 4 other studies from the Chinese. There is no data available for the North Indian population. It is a pilot study which will pave way for a large-scale multicentric population-based study. Any alteration will help us devise rapid diagnostic kits and will become a target site for future CRISPR technology. So I'd like to conclude that 374T by A polymorphism is significantly associated, while 429T by C is not associated with polymorphism. Collaborative efforts are needed to develop an international and national consortium for diabetic retinopathy patients, and large-scale genome-wide association studies are the need of the hour to identify these. Thank you. The limitations of my study were serum RAGE levels. We have not correlated with them, which could help in determining what is the translational efficacy of this polymorphism. Any number of polymorphisms are associated. We have restricted ourselves only to RAGE gene polymorphism in the promoter region, and it could not be, this was a cross-sectional study. Effect on the progression has not been noted. Thank you.
Since you are seeing the gene to be more common in both diabetics with retinopathy and without retinopathy,
yes,
as compared to controls,
yes,
right? But there's no difference between both the diabetic
yes,
groups. So how does this information help us?
Ma'am, the odds of this mutation occurring in the diabetic patients with retinopathy is more compared to those without retinopathy. However, if the sample size would have been more, then we could have, because the p-value that we found was 0.03, 0.3. So if the sample size and due to the funds restriction, we could not increase our sample size.
So, okay.
That
So
would
your
have been-
sample size was calculated to find a difference from controls or to find a difference between the two diabetic groups?
Ma'am, if the aim was to between the two diabetic groups, but with in the given sample size,
You couldn't find
we
that
couldn't
difference.
find. No, ma'am.
And is this genetic difference that you noted in your subpopulation the same as what is reported in literature from
yes,
other population ethnic groups?
Similar study was done with National Eye Institute in Arvind and SN in 1991. They had studied 13 genes and found this 374 T/A polymorphism to be significantly associated for the RAGE gene. But they had most genes because it was a large study with around 500 subjects.
No literature in Western group.
No, no, sir. It is mostly in the Southeast Asian sub. Yes, sir. There are 5-6 studies from Chinese population. This is the second from Indian population, and there is one study they are doing in Pakistan right now. They have not, I think they are about to publish. No, sir, not in Western literature. No, sir.
Why?
Sir, because China and India are the predominant areas, diabetic capitals of the world, so could be, and sir, large-scale funding is needed for this.
Thank you so much.
Thank you, sir.
Dr. Jawad.
Which is to study the biomarkers in central serous chorioretinopathy on OCT angiography and its correlation with the clinical course of disease. Central serous chorioretinopathy is a common chorioretinal disease which is characterized by the serous detachment of the neurosensory retina from the retinal pigment epithelium. It's the most common cause of the central vision loss with the incidence of 1:10,000. Several risk factors have been identified such as high corticoid levels, type A personality, uncontrolled systemic hypertension, etc. OCT angiography is a new non-invasive non-dye depth resolve technique which may be used to investigate patients with CSCR. The concept of OCT angiography is detection of the changes in blood flow in the vessels in a static eye without need for dye injection. By calculating the decorrelation of the signal amplitude from the repeated consecutive B scans at the same cross-section, a contrast between the static and the non-static tissue is created and generates a vascular decorrelation signal that enables visualizing 3D retinal and the choroidal vasculature. Our aim in this study was to identify the predictive biomarkers in patients affected by CSCR on OCT angiography and its correlation with the clinical course of disease. It was a prospective hospital study from September 2021 to September 2022. Inclusion criteria were age greater than 18 years, patients with clinical history of acute CSCR with presence of SRF involving the fovea on structural OCT. Exclusion criteria were presence of any other retinal disorder potentially confounding the clinical assessment, any previous treatment on CSCR, and presence of significant media opacities. Patient underwent a complete ophthalmic examination and a standardized imaging protocol which included fluorescein angiography and structural domain OCT. All patients underwent OCT angiography, acquired OCT angiography volume 3:3 mm. Fisher exact test and the student paired t-test was performed to test the interdependence between the biomarker and analyzed, and p-value less than 0.05 was considered as statistically significant. A total of 26 eyes of 25 patients, 2 females and 23 males who met the inclusion criteria were included in this study. Mean CSCR duration at baseline was 10 weeks plus minus 4 weeks. OCT angiography showed at outer retina level there is detected the presence of abnormal blood flow. OCT angiography showed 3 main anomalies at the choriocapillaries level, that is the presence of dark area which were frequently associated with the serous retinal detachment, presence of dark spot which were frequently associated with the retinal pigment epithelial detachment, and the presence of abnormal choroidal vessels. After a treatment of 10 weeks plus minus 4 weeks, mean central macular thickness significantly reduced and mean BCVA improved. The age distribution was maximum between the age of 31 to 40 years. Male ratio is predominant, and the visual acuity at first visit was between, majority was between the 6/18 to 6/24, and CMT was between 301 to 400 microns. the mean logMAR was improved from 0.6 to 0.2, and the last visit CMT was between maximum in 201 to 300 microns. Automatic segmented choriocapillaries and the outer retina OCT features in CSCR patients were dark area was found in 22 patients, dark spot was found in 5 patients. There was irregular flat and hyperreflective deposit were also seen, and abnormal vessels were seen in 12 patients. This is the fundus photo of the 32-year-old male showing the shallow detachment at the macular level. Same patient, fluorescein angiography showing the blood appearance, and the OCT of the same patient showing the shallow detachment with the pigment epithelial detachment. On the OCT angiography, on the outer retina level, there was abnormal dilatation of the vessels, and dark area and the dark spot were seen at the level of choriocapillaries. This is the same patient at the 3rd month. The dark area was resolved by the end of 3rd month, but dark spot was still present due to the pigment epithelial detachment. And the discussion of my study was, in our study, the dark area corresponding to the diffuse or the focal, foggy, ill-defined, low detectable flow areas in the choriocapillaries layer. The dark spot corresponding to the black, single or multiple well-delineated areas where no flow was detectable at the choriocapillaries. Conclusion was, it showed dark areas and dark spots as common findings observed at the choriocapillaries in eyes with CSCR. It also revealed the presence of abnormal dilated choroidal vessels at the same level, persistence of biomarker during the clinical course of disease, and even after the resolution of the SRF improves our understanding towards the disease pathophysiology. Thank you.
Thank you. Any questions?
Is CSR a vascular disease?
Ma'am, choroidal vascular disease.
Is it a choroidal vascular disease?
Yeah,
pachychoroid, pachychoroid. But the dark area that you are describing is the shadowing effect of the fluid on the vasculature and the distortion, as well as the dark spot. These are both actually artifacts in OCTA.
Maybe,
that's just because you had fluid and the fluid resolved. They are not really findings or features.
When we see through enhanced depth OCT angiography, we can actually detect the low detectable areas which are not by the due to overlapping by the shallow detachment or by the fluid. There is actually presence of dark areas which showed the low detectable areas on those choriocapillaries. Thank you.
How did you treat these patients?
Certificate. Omkar sir to give certificate.